Good evening, everybody. I'm Dr. Cosmin Dima from Romania. My topic for today is sinus lifting. We'll talk about anatomy and also some complex cases. First of all, I would like to thank you, MIS and Dental Tribune, for inviting me. So let's start with the anatomy. The maxillary sinus is a pneumatic space out in the body of the maxilla that communicates with the external environment by way of middle meatus and nasal vestibule. It is also known as antrum of Haemul. There are some important landmarks, like you can see in this picture, we have to know about. The first one is maxillary sinus opening, also called ostium, which is very important, and I will detail a little bit later why. The middle meatus, medial wall of the sinus is also very important, and I will show you a little bit later why. The lateral wall of the sinus is important because when we perform the sinus lifting, the external sinus lifting, of course we prepare the window in the lateral wall. And the floor of the sinus and alveolar recess is also important for internal sinus lifting and implant insertion. In this section we can see the medial wall and also the anterior wall, and the cross section shows the lateral wall. And what is important here is that we can see some arteries from the beginning, and we can avoid cutting this artery and having some problems during the surgery. So let's see some anatomical landmarks which are important. And these are on the medial wall, and we can see here a diameter of only 3.3 or 3.7 millimeters. Do you know what I'm talking about? I'll show you one more detail. Look at this guy. He aspirates through the nose this blue liquid. Then he pressed the nose and tried to blow the air. And the liquid is coming out from his eyes. I'm sure now you know that I'm talking about the nasolacrimal duct, which is the passage leading downward from the lacrimal sac on each side of the nose, through which tears are conducted into the nasal cavity. This passes downwards medial to the antrum and to open into the inferior meatus. Why is this so important? Because if we press it too much, we can compress this nasal duct, we can compress it, and the tears will be on the patient face. And if the patient will have tears for the rest of his life, tears on his face, for sure he will try to make the doctor have tears on his face. And of course we don't want it. So we have not to press too hard when we insert the bone inside the sinus. Do not press it too hard on the medial wall. Another important landmark is the ostium. You can see it here on the CBCT. You can see it on the caliper here, and also from the endoscopic point of view. And also this is very important because we have this communication between the sinus and the external environment. And I will detail a little bit later. Let's talk about the nerve supply. The nerve supply is coming from the maxillary artery, and we have three branches of the superior alveolar nerve, like posterior, anterior, and middle. But we have to know also the infraorbital nerve, because sometimes when we need to perform the external sinus lifting, the upper jaw is not so high, and the distance between the crest and the infraorbital nerve is not like in this picture. So we have to be very attentive when we try to make an incision at the periosteum to increase the flap mobilization, not to section the infraorbital nerve, which looks like being so far, but as I told you, sometimes it's not so far away from the crest. The blood supply. The blood supply is coming from the maxillary artery, and what is very important here is that we have to know about intraosseous branch of posterior superior alveolar artery. Like you can see it in the picture. This is very important because sometimes when we prepare the window on the lateral wall, we can cut this artery. And of course, this could lead to some complications, and I will tell you later how we can manage these complications. But of course, we can prevent this because having sections on the CBCT, we can see in the lateral wall the artery. So sometimes we can avoid cutting it. Let's see the histology of the maxillary sinus. We have to know that the maxillary sinus is lined by three layers. One is epithelial, the basal lamina, and subepithelial layer with periosteum. The schneiderian membrane, when is healthy, is only 100 from 100 to 500 microns. That means if the membrane is very, very thin and is also attached, we have to be very, very gentle to detach it. And we have to have the perfect and the proper instruments to have the perfect contact. And the perfect contact means that we have to keep the instruments in contact with the bone every second. Do not press on the membrane, just keep the contact with the bone and just enroll, easy to detach the membrane from the bone. We can see also the goblet cells, which are that ones who produce the mucus, and it's very interesting to see that we produce about 1.5 liters per day. This is very important to have the ostium patency, otherwise the sinus would be very compressed and of course the patient would have headache. So the healthy sinus need the natural ostium patency, normal mucus composition, and of course efficient mucociliary transport. Otherwise the patient would have sinusitis. But maxillary sinusitis could be provoked by other anatomical variations, like variations of the uncinate process, bulla ethmoidalis, middle turbinate, ostium, nasal septum, and nasal masses. That's why it's very, very important to have collaboration, and we have in our team an ENT surgeon also, and every time we start sinus lifting planning, we decide all together the plan, and I will detail a little bit later the clinical cases. Of course, it's very, very important to use 3D pre-surgical evaluation because there are statistics saying that on the panoramic X-ray we can see only about 60 to 70% of the details, but when we are trying to make the sinus lifting, we need more than that. That's why we need a CBCT to prevent major postoperative and also intraoperative complications, but also to prevent the medical legal issues. Let's see the complications. The complications could be intra-OP or post-OP. Intra-OP, the most frequent is membrane perforation. And looking in the literature, we can see studies with different values like from 20 or 10% to even 40-50% of perforations. That means that this intervention must be done very, very gently. Otherwise, we can perforate it, but we can manage it. If the perforation is not too big, only a few millimeters, we can protect it with a resorbable collagen membrane, and double layer is recommended. I will show you on the clinical cases. Abnormal bleeding due to lesion of the posterior superior alveolar artery, like I told you, we can drop some anesthetic with vasoconstrictor if the artery is not too big, and in severe cases we can use surgical wax, or sometimes we need ligature, arteries ligature. Post-OP, pain is considered like a complication because we can have some small pain in the first 3 weeks, but after 3 weeks the pain is considered complication and further evaluation is needed. Dehiscence. If the patient has dehiscence, the most common thing is to use the chlorhexidine gel and mouthwash. And the worst thing we can do is to remake the suture, because we have also there a necrotic tissue, and if we compress it again with the suture, we make it more necrotic, so we can enlarge the dehiscence. Infection. If the patient have infection, usually this infection is not in the sinus, it's in the augmentation material, and if we prescribe the antibiotics for 10 days, it will be solved in most of the cases. And sometimes the implant could migrate into the sinus. Of course, in this case, we have to make a reintervention and to take the implant out. So, the complications are infrequent and localized and readily resolved. The resolution of symptoms after 3 weeks suggests a normal post-OP period. Pain is absent, and if it's present, this is a warning sign. So you can tell the patient he could have swelling, he could have ecchymosis, mild to moderate discomfort, not pain, or just a little pain, but this within 3 weeks. After 3 weeks, every symptom is a warning sign. Of course, minor nose bleeding might be present, especially when the membrane is perforated, and we have to tell this to the patients, because otherwise they are very frightened if they see blood coming out from the nose. We have the 7 golden rules for a predictable result. And we start with the incision. The incision is very important and must be big enough to have a perfect access. After that, if we have a perfect access, we can design a perfect bony window, which is designed to allow ideal curette's position. Always keep the curette in contact with the bone. Otherwise, if you press it on the membrane, you will perforate it. So never push the curette directly on the Schneiderian membrane, because you will perforate it. Just keep it in contact with the bone and roll easy to detach it from the bone. Never keep the ultrasonic tips in contact with the bone for more than 1 second. And I'm talking now about the intraleaf system, which is a system used for internal sinus lifting using the piezosurgery. And I will show you one case with this technique. It's very important not to stay with the tips too much in contact with the bone, because if the contact is too strong with the bone, the saline solution could not enter between the bone and the tip, so we can provoke necrosis. Protect the Schneiderian membrane with collagen sponge or collagen membrane. I will show you also on the clinical cases. And prepare your flap from the beginning to have a perfect closure at the end. This is very important. I saw many times some colleagues making the augmentation, after that trying to put the flap in place, and after seeing that they don't have enough elasticity, they make incision in the periosteum and then try again to put it, and so on. We have 2 big disadvantages if we make it like this. First of all, we don't see it because we have also put there the augmentation material, and then when we cut the periosteum, we push the granules from the augmentation material inside the tissue, and of course the patient will have swelling and maybe ecchymosis more bigger than it could be. So we use this technique. Sinus lifting doesn't matter if this is internal sinus lifting or external sinus lifting. We use it for inserting the implants. But before inserting the implants, we have to know some aspects to have success. And we can see here the most important aspects for a final predictable result. I will show you here the most important, like biotype, implant positioning, emergence profile, which is very important, and also soft tissue quantity and quality. and I will detail everything a little bit later. Implant planning. We have to know from the beginning some rules. And some rules are that when we insert the implant, we have to insert it vestibulo-oral in cingulum position if we are talking about the frontal area, or centered if we are talking about the lateral area. Coronoapical, we have to insert it according to biological width. And this is very, very important when we insert the implant immediately post-extraction, because the bone will remodulate, and if we don't keep in mind the remodulation according to biological width, we can end up with the implant outside of the bone and sometimes outside of the soft tissue, which of course is very bad. Mesiodistal, we have to keep more than 1.5 millimeters to adjacent teeth and more than 3 millimeters to adjacent implants. And the angulation is very, very important. And in the frontal area, we know that it's very difficult to obtain the perfect angulation, but we have to keep in mind that the ideal one is 70 degrees. So, before taking the scalpel, just think about three very important criteria. The first one is the gingival biotype. The second one is interproximal height of the bone. Why? Because if we cut the papilla in a case with the interproximal height of the bone class 3, we can never rebuild that area. So the patient could come with one problem and leave with two problems. And of course, the buccal bone of the adjacent teeth is very important. If we insert the scalpel into the sulcus and cut the fibers in a class 3, of course, the patient will have recession. So again, she would come with one problem, and in this case would go with three problems, having in mind this recession of the adjacent teeth. Of course, we need, like I told you before, a very good team. And we have in our team an OMF surgeon and an ENT surgeon, and we plan every surgery together, and I recommend you to do the same. So now let's talk about the sinus lifting. There are two steps, like external sinus lifting or internal sinus lifting. When we are talking about external sinus lifting, we have two options, trap door, or we have the option of open window. And the other one is internal sinus lifting. We can do it with piezosurgery, like you'll see in the clinical cases. It is called intralift, or you can do it with the other systems. So case 1 is about intralift. I will show you at the end, at every case, even a movie, to see more details, and I will try to detail every step to have a global image at the end to do it without any risk. So, this is a case which certainly must be decided before starting talking with our ENT surgeon too. We can see on the left side that the sinus is completely full, and we can notice also some foreign bodies in the sinus. So searching the literature, this is a perfect case to be sent first of all at the ENT surgeon, and after that we have to perform the sinus lifting. And we have all the criteria to talk about every kind of pathologies. Unfortunately, we don't have time today to talk about all the criteria of pathologies, but I will tell you as much as possible in only 1 hour. So, coming back to our case, first of all, we sent the patient to the ENT specialist, and first of all, we have to make the treatment plan all together. And when we make the treatment plan, we have some questions like single or stage approach, technique, what incision, what flap design should we use, bone augmentation, what kind of membrane, and augmentation material, and of course what suture technique and what suture material. In this particular case, we have decided to have stage approach. So first of all, we have to remove the tooth because we are sure that the tooth generated this pathology into the sinus. Then we make ENT surgery and then intralift. The most important thing is to reduce and to take out the cause, and after that to treat the sinus. Otherwise, if the cause is still here, is still there, we will have the effect sooner or later. We decided to use a full flap, a resorbable collagen membrane, xenograft. We use xenograft for bone augmentation into the sinus, and we use PTFE suture. So before the ENT, we can see the sinus was full, and after ENT surgery, the sinus is clean, so we can perform sinus lifting. We can see that we have extracted also the molar, and now we can start. We can see also on the CBCT the difference between first visit when the sinus was full and after the ENT surgery, the sinus is clean. So now we can start. We can do the osteotomy. After that, we can start with the piezosurgery or the other systems. And what you can see on the third slide is a special probe with a ball, a bigger ball, not like the perio probe. We use this kind of probe to feel the membrane and to check how much we have raised the membrane, and you'll see it better in the movie. So we have inserted the implants, made the bone augmentation, protected with the collagen, and then make a suture. And you can see here that the bone augmentation into the sinus is more than we need, because sometimes we can detach the membrane very easy, but sometimes it's very difficult. We use in this system a trumpet. It is called trumpet, a tip called trumpet, which pushes some saline solution with some bubbles of air to detach the membrane. And sometimes the membrane from the very beginning is detaching at 16 millimeters, like in this case. So we have to put a little bit more material, but after the healing process, after 6 or 8 months, you will see that the area will be more compact and the height will be not so much like in this picture. Of course, we have to insert the implants respecting the biological width. This is very important for the long-term stability. Otherwise, if we have here a thinner biotype, we have to rethink the implant insertion and maybe use 2 steps for bone augmentation into the sinus, first of all, and after that to insert it a little bit subcrestal, and then to make the final restoration. In this case, we have to extract this premolar. Unfortunately, you can see here the gingival contour around the implants. And then we decided to make a provisional on the implants after integration, after 4 months. And we can extract this premolar, which was hopeless, and make a provisional on the implants with the extension, because the patient didn't want to touch the other teeth for a provisional, so we have to make it in 2 stages. After extraction, we can see the intact septum, because the extraction was made atraumatically with piezosurgery. And then we have to insert the implant in the ideal position from the prosthetic point of view. And you can see here how we check it from different angles, and it's better to check it from different angles, otherwise you can see it too late that the position is not ideal and you have to use some angulated abutments or to make some more intervention to put it in the ideal position. So now we can see the implant. We respected the ideas I told you before of more than 1.5 from the adjacent teeth and more than 3 millimeters to adjacent implant. And what is very important, we inserted at more than 2 millimeters from the buccal bone. We know that this is the most frequent resorption where occur on the buccal wall. So we have to keep in mind to augment this area with a stable material in time, like xenograft, and to protect the area as much as possible to obtain at the end a concave profile. And we can help the concave profile with the provisional. After inserting the implant, we make bone augmentation around the implant, and we just protect it with a collagen sponge. We never raise the flap when we extract a tooth and make immediate implant insertion. And Dennis Tarnow said that this is the biggest mistake in the world, to raise the flap after extraction. Why? Because we have two big disadvantages. Raising the flap on the vestibular area, we provoke recession because we take out the periosteum from the bone and we make the bone suffer, so of course we increase the resorption. And the other one is that we will mobilize the soft tissue and we will put a non-keratinized soft tissue on the crest. And of course, at the end, we need maybe one more intervention to move the soft tissue and to generate the keratinized soft tissue around the implant. So in this case, and in every case like this, we just place a collagen sponge. It's very important what kind of collagen sponge we use, because some of them are disappearing after 1-2 days, but the others are disappearing after 2-3 weeks. So enough time for healing of the soft tissue around the implant. And then, of course, we design a provisional to compress the tissue and even to generate the papillae. Like you see in the picture, we let some spaces between the crowns to let the tissue growing. And you can see after a few months that the new soft tissue contour is better. And now it's time for the final restoration. This is immediately post cementing. After that, for sure, the soft tissue will grow even more between the crowns. And you can see it on the X-ray also. We started with this full sinus, and after that the sinus is clean, the crowns in place, and everything is very stable. So let's see now the movie. I will try to detail a little bit on the steps of the movie too. This is very important to move the tip continuously, and to move it only vertical, not horizontal, to have a good irrigation between the tip and the bone. Otherwise, you can provoke necrosis. And if you move it laterally, you can break it inside the osteotomy, and this is not so good and not so easy to take it out. This is the trumpet. The trumpet must fit perfectly. You can see the bubbles, saline solution with bubbles of air, and we compress the membrane and we raise it. And we know that the membrane is raised after we let the patient to breathe, and you will see how the saline solution is moving, like you can see it now. I insert the augmentation material, but first of all I inserted the collagen sponge to protect the Schneiderian membrane. This is the special probe, I told you, with the ball. And before inserting the implant, I put one more time the collagen sponge, not to let the implant have contact directly with the cnidarian membrane, because I use very aggressive implants, so of course it's not good to have the contact directly from between the implant and the cnidarian membrane. The second case is a little bit more complex. We have here an impacted wisdom tooth, like you can see on the X-ray, and one of the roots is inside the sinus. We know that many times we see molars like loops being into the sinus, but they are not. In this case, one of the roots was in the sinus. We knew it from the very beginning from the CBCT. So first of all, we have to talk about the treatment plan. And please don't start without having a treatment plan. Ideal having some more ideas from your team. And we have the same questions, but this time different answers. So in this case, we can do it in a single approach. We can extract the wisdom tooth. We can make external sinus lift, insert the implant in the same session. We use a crestal incision, a full flap. We design a full flap. We use resorbable collagen membrane, xenograft for augmenting the sinus, and in this particular case, we have used a continuous matrix suture with a PTFE suture. So let's see the clinical case. One of the few times when I see the patient with such a big width of the bone, usually they have nothing, but in this case the patient was very generous, but unfortunately we need augment the area on vertical this time. So after raising the flap, we can see the impacted wisdom tooth, and we decided to extract it with a traumatic extraction held by piezosurgery, like you can see in this picture. After we use the piezosurgery, we can extract the tooth easily, like you can see it in the movie. And this is the root which was inside the sinus. And of course, if the root was inside the sinus, we can see the membrane perforated, like you can see it here. In this case, there is no problem to perform external sinus lifting. And when we have perforations less than 3-4 millimeters, we can protect them with a resorbable collagen membrane and continue like nothing happened. Of course, it's better not to have perforations, but sometimes anatomical variations could lead to such a case. So then we start with preparing the window. In this case, the lateral wall was very thick, like you can see in this picture. And when the lateral wall is very thick, we better use the open door technique, not the open window, not the trap door, because it's very difficult to enroll inside the sinus this thick bone. And we can use it, of course. We don't put it in the garbage. We use it in a bone meal, and after that we put it with the bone augmentation inside, like you'll see a little bit later. So now it's time to detach the membrane. Do we have any rules when we detach the membrane? When we start, should we start with the crystal, mesial, or distal wall? Yes, we have some rules. And first of all, we have to start with the crestal area, because the access is the easiest one, and it's very important to have the easiest access at the beginning, and then after we detach it a little bit, the membrane is not in tension. So we can continue with the distal wall, and only after that with the mesial wall. Searching the literature, we can see that the most frequent perforations are on the mesial wall, and this is because the access is more difficult, and sometimes we are afraid to do the window as long as we need because we are afraid of the roots. Usually we have teeth at the mesial part and the patient doesn't have teeth at the distal part. So we are afraid to enlarge it to mesial, and that's why we don't have a good access. If we don't have a good access, just remake it. Just remake the contour of the window. Don't try to detach the membrane if you don't have the correct access and you don't feel the bone because you will perforate it. But we need also the ideal instruments, and I recommend you to have at least 4, 5, 6 curettes with different angulations. These are 4, but the other ends are different, so I have 8 different approaches with this kind of instruments to solve every situation, because there is nothing worse than to perforate the membrane because you don't have the right instrument. So keep this in mind before starting. Just make sure you have everything for making the detaching possible. And then, of course, we can, at the first step, we have to make the osteotomy. And after the osteotomy, we insert the resorbable collagen membrane inside the sinus. Then we insert the augmentation material, and after that, we can insert the implants. And you can see here the implant insertion. Try to check from different angles, like I told you before, because sometimes you are sure that they are in the perfect position, they are parallel, but at the end you see they are not. So if you check the implants from different angulation, different positions, you may end with a better result. After that, keep in mind that we have to insert on the vertical the implants according to biological width. So according to the thickness of the gingiva, we decide if we insert them crestally or subcrestally, to keep in mind the bone remodelation. I have used in this case the bony window in a bone mill, and after that for bone augmentation. And I have protected the area after tooth extraction with collagen sponge. This is enough. If we have 4 walls, we have a very good remodelation, so we don't need there to put a lot of augmentation material. And this is another rule of Dennis Tano, that if we have all the 4 walls around, even around an implant, he said that we can let it like this without any augmentation material and the regeneration will be good. Of course, this is a little bit risky, so I would not recommend around implants, but in this case, after wisdom tooth extraction, collagen sponge is enough. Very important thing, we have to stabilize the graft. One of the most important criteria for having success when we make bone grafting or even tissue grafting is that the graft must be very stable. So we insert the collagen membrane inside the sinus. After that, we put the augmentation material, so we compress a little bit the membrane, and then the membrane is very stable at the upper part. So if we suture it at the lower part, the graft will be very stable, so that we don't need any other complicated sutures or pins or something else. Just with one suture at the lower part, we have the graft very stable. And searching the literature, we can see that augmentation using the sinus lifting is the most successful bone augmentation. Why? Because the graft is very stable and we have a very good vascularization. After healing process, we can see everything is fine, and 10 days OP looks like this. So now the patient is ready for prosthetics after 8 months. In this case, you can see that the implants are inserted according to biological width, so we know that we will have a stable result and a predictable result in time. On the X-ray, looks like this, and we can see now the movie. These are the tips using for extracting the tooth. And after that, with the forceps, it is easier. This is in real time. We have to detach this bony window very gentle, not to perforate the membrane. We start crestal, then distal, and only after that on the mesial wall. The implants insertion are also very gentle, not too fast, not to compress the Schneiderian membrane too fast. Let time for the granules to go away from the implant way. And keep in mind the biological width and the bone remodelation. The next case is even more complex, and we start like this. We can notice on this X-ray assist on the left sinus. You can notice it on the right corner on the CBCT. So, of course, we start with a treatment plan, and every time we have to start with a treatment plan before every stage we are going to do. So the same questions, but some different answers. In this case, single approach. We start with extraction. In the same time, external sinus lift, cyst removal, and implant insertion. Everything in one session. Of course, if it's possible, I want to end the surgery in only one session, even if it's very complex. And I try to treat my patients like I am the patient. And of course, if I would be the patient, I would like to have only one surgery to solve every problem and to be as easy as possible. So in this case, again, crestal incision, full flap, resorbable collagen membrane, xenograft. We don't use autologous bone into the sinus. Actually, it's the only one situation when autologous bone is not the golden standard or is not indicated at all, actually. And we use also the PTFE suture like in every case. So this is the cyst, like you can see on the right side. According to literature, a cyst like this, if it is less than 75% of the sinus, could be take out in the same session with external sinus lifting without any problem. But of course, we talk every time with our ENT surgeon and we decide together if the first step would be ENT surgery or we can do it in our office. In this case, we decided to do it in our office. We have to extract this root. Actually, it's only the palatal root of the molar. And you can see here the full flap. Then a traumatic extraction with piezo. And then we design the bone window to take out the cyst and the fluid from the liquid from the cyst, as you will see it a little bit later on the movie. We use open door technique in this case because we need to access the Schneiderian membrane to aspirate the liquid, and it's very important to aspirate it before detaching the membrane. So first of all, just make the window, then take the window out. After that, you can use the syringe to aspirate, take the cyst membrane out, and after that you can detach the membrane. Otherwise, you cannot do it properly and you have more risk. So you can see the fluid from the cyst aspirated with a syringe, and then with this instrument we just try to remove it very, very gentle. And you'll see it on the movie that after you pull it out a little bit, you try to keep it from the contact with the Schneiderian membrane, and then pull it out again 1-2 millimeters, and again until you take it out completely. So you can see here the perforation after the cyst removal. This is not a problem because we can use a resorbable collagen membrane to protect it. We have to keep in mind that the collagen membrane must be 3 times more, 4 times more than the perforation, not to have any chance to aspirate the membrane inside the sinus. Like you can see here, we put the collagen membrane, the first layer, because in these kind of situations we use 2 layers. After that, we make the osteotomy, and then we put the membrane, the second layer, the bone, and insert the implants. In this case, we put the bony window in the same place, like you can see in the picture. Sometimes we use it like you have seen before in a bone mill, and we use it for bone augmentation. This is the second layer of the collagen membrane, which will cover the area, and you can see now the implant's position according to biological width. You can see on the area of the extraction that we kept in mind the future remodelation, so the implant is inserted subcrestal, and of course, according to biological width and the bone remodelation we know about. After that, we make the suture, and we can see the soft tissue remodeling using a provisional. And we try to develop from the very beginning, from the provisionals, the papillas. So after the surgery, now the sinus is clean. You can see on the left side the cyst, on the right side the sinus is clean. And we can see now the movie for more details. Try to detach the bony window very gentle from the Schneiderian membrane, like you can see here. You can see how much liquid was inside the cyst. First it was yellow and then a little bit red. And look how we pull the membrane, the cyst membrane. The pressure is only at the base of the cyst. After that we can start the Schneiderian membrane detaching. Like I told you, distally, crestally, distally, and then missing. We protect the perforation with this resorbable collagen membrane, 3-4 times bigger than the perforation. So this is the first layer, and after that we use the second layer. So there is no chance that augmentation material could go inside the sinus. This is the second layer, which is bigger, of course. We insert just the part inside the sinus. After that we press the bone inside the sinus, so we fix it at the upper part. And then we just need to make a suture at the lower part to have everything very stable. So it's time for take-home message. For intralift, very important to have a proper irrigation, otherwise you can provoke some problems to the bone. If the saline solution is not in contact every second with the bone, you can provoke necrosis. The tips must describe only vertical movements, otherwise you can fracture them, and it's not so easy to take out fracture tip from the alveolotomy. The trumpet tip must fit perfectly, otherwise the liquid will go out and will not press the Schneiderian membrane, so you cannot raise it. And the collagen sponge or membrane could be used to protect the Schneiderian membrane before inserting the material, the augmentation material, and also before inserting the implant. For external sinus lifting, the recommendations are CBCT is very important for a correct diagnosis. As I told you, on the panoramic X-ray, you can see only 60–70% of details, and of course, is not enough. A proper flap is mandatory to have the best access to the lateral wall of the sinus, and if you have a good access, of course, you must design the window so you permit the ideal curate's access into the sinus, which is mandatory. And don't forget, never push the membrane, just keep the curates in contact with the bone. Don't push the membrane because you will perforate it. And of course, the collagen membrane could be used to protect the Schneiderian membrane if the perforation is small. Steve Jobs said that the only way to do great work is to love what you do. And I'm sure that you love what you do. That's why you are here. So the only thing I could say is I recommend you to dream high and to follow your dreams. Thank you very much for your kind attention. Thank you. The first question is why to do 3 implants in quadrant 2 at the case 1? Because as you saw, we had to make a 2 steps intervention. As I told you, the patient didn't want to touch the other teeth, so we cannot make any provisional without touching the other teeth. That's why we kept the premolar to have retention on it, and after that we insert the implant after extraction. Otherwise, we cannot do it with only 1 implant distal because we had to make a provisional on mixed implant and tubes, and I don't agree with this kind of treatment. Other question from Professor Anton Joseph Wojtik is no pre-planned surgical drill guide. In this case, no, but I agree with the surgical drill guides, and of course, this is the future. Dr. Jose Luis Brenes Barquero asked us, could you extend your flap to the canine? Yes, of course, you could extend your flap. I try to be minimally invasive, and I don't want to extend it more than it's necessary. So in that case, I thought it's enough like that. Munish Kumar, I was told to start lifting membrane from distal side by Ostem speaker. What are the disadvantages of doing so? There is no disadvantage. The idea is that you have to start with easiest access, and in more than 90% the easiest access is crestal. If you have easiest access distal, of course you can start with the distal. But as I told you, frequently is more easy to start crestally. How to differentiate between cyst and sinus membrane? Yes, you can make the difference because after you will take out the cyst from the liquid from the cyst, you can see the difference in color and even in the texture. So it's not so difficult. What is the protocol with the preference of I don't understand here. Very nice, thanks, great. These are only nice words, not questions. One more question. When is indicated in case of membrane perforation to suture or to cover the perforation? Yes. When the perforation is not so big, like I told you, 3-4 millimeters or even more, I used even in 6 millimeters just protection of collagen membrane. Usually I try to avoid the suture because sometimes it's not so easy to suture the Schneiderian membrane, and sometimes you can enlarge the perforation. So the most simple way and the best way is not to touch the membrane, just to protect it. And the best protection is with a collagen membrane, resorbable collagen membrane, 4 times bigger than the perforation. Keep this in mind. Otherwise, you can the patient could aspirate it inside the sinus. So if you have the perforation bigger than this, of course, sometimes you need to suture it, but we have to be very attentive because it's not so easy, and probably you could enlarge the perforation. So thank you very much again. I wish you a beautiful evening and happy patients.